Right, afternoon everyone. What my task is in the next 5 or 10 minutes to go through and talk about some of my experience of integration as a consultant respiratory physician at New Cross in hospital in Wolverhampton. Integration comes in many different forms. We talk about integration, we know where the boundaries are that have been there since 1948 and the existence of the NHS, but everyone does it in slightly different ways depending on the geography and your already structure that's available. So the first part is vertical integration. So I'm currently clinical lead for vertical integration, our trust. So before 2016, several GPs actually came and talked to our chief exec. They have concerns about the future of GP, about workload, work-life balance, etc., and actually asked to become merged with the trust, become part of the trust. In 2016, this actually happened for 3 practices to start off with. They became integrated with us. Their GMS contract was subcontracted to the acute trust, and all of the staff within the GP practice became salaried, including the GPs. Currently there are 9 practices across Wolverhampton who have integrated with the trust. It's become everyday working now. Recently we've got an additional division within the trust, a Division 3 that oversees primary care services. Very much streamlining back office functions and recruitment with support from CQC visits to the GPs, locum recruitment, procurement, etc. But our task was also looking at clinical work stream. How can we change the pathways to work closer together, particularly across primary and secondary care? And this is not something that changes overnight. Some of the examples of the work we've been doing is working with end of life and the national GSF team of improving the education and provision of end of life across Wolverhampton. Looking at NHS health checks, trying to increase their uptake as they're not taken up a lot within Wolverhampton. Long-term catheter plan, there are patients out in Wolverhampton with long-term catheters and no immediate plan for them to have trial without catheter for some. Pharmacists across all of the VI practices and other specialists have been interested in doing more work as well. From a respiratory point of view, a bit of work that's going on currently is looking at EMIS templates for COPD annual reviews. So EMIS templates are set, but they can be individualised across the different GP practices, and actually there were 4 different templates being used within our 9 practices, of which some had pulmonary rehab and some didn't. We looked at the baseline data for annual reviews within primary care for the COPD patients, and just under 85% had no record of pulmonary rehab in patients with COPD and an MRC of 3 or more over the last 12 months. Less than half had a number of exacerbations recorded over the last year, and only a third had inhaler technique checked within the last 12 months. That is our baseline data. What we have done is got a standardised template. We've made sure we've embedded referrals to make it easier, so it's one-click referral, not having to go and find another website and a referral on, for oxygen, for spirometry, and for pulmonary rehab. And we've embedded the leaflet for patients for pulmonary rehab, so it can be printed off then and there, and they know what's happening and what they're going to be going to. Our plan is, after 6 months of doing this, is to pilot and look at the data again. Are we doing more of what we should be doing for the annual for COPD patients, and ideally to roll it out across all Wolverhampton GPs. It should not just be about the GPs that merge with the trust. That is very key for us. So that's just briefly about some of our vertical integration. We've been also I've been chairing a chronic respiratory MDT for a long time. MDTs exist in many different forms, but this is for looking for people with chronic respiratory disease, not lung cancer, which obviously has been going for a lot longer. We have fortnightly meetings, a great variety of MDT team, including palliative care in the room. And we have a standardised performance shared on our portal at the Acute Trust and also with the GPs. Predominantly we used to look at readmissions, people coming in a lot, but actually what we realised, a lot of these patients are end-stage chronic respiratory disease patients with significant symptoms, and realised there was actually an opportunity for closer working with palliative care. When is the right time for palliative care to be involved with end-stage respiratory patients? And following that, we set up a joint palliative respiratory clinic. So Worcester have previously, there have been abstracts and posters have done this. Their respiratory consultant and palliative care consultant are in separate rooms in the hospice, but what they found with their numbers, which were low numbers at the time, is they reduced the lengths of stay and admissions for these patients and found that patients more likely died at their third place of death. We identified a need in Wolverhampton. We set up these joint monthly clinics from June 2015, also encouraging the patients' community matrons to be there for ongoing conversations and obviously relationships that had already been formed. The clinic happens at hospice. It's really important that the patient knows that before the letter arrives on their doorstep. They are referred from my secondary care colleagues, making sure that their treatment is already maximised before they're referred, or via the MDT that I've already mentioned as well. 45-minute appointments, a lot longer than most of us see within respiratory, but it's important to have the time to talk about difficult conversations and symptoms. 1 clinic a month. We sent a integrated palliative care outcome scale questionnaire before and after clinic, and that looks at palliative care needs and specific symptoms, particularly shortness of breath. We also do an evaluation questionnaire for patients and carers after clinic to get their feedback. Majority of patients, so about 86% of patients, are seen only once, because what we tend to do is leave follow-up with community matrons, but always happy to see people again. We have observers seeing how we do clinics, and we do encourage carers to be present because they are key for supporting the patients and also do suffer a lot of stress for supporting these patients too. A significant number of our patients are COPD. Being a COPD specialist before, that's how I started that referral in, but 20% pulmonary fibrosis, they also suffer significant breathlessness. We'd, as of May last year, seen 70 patients, that's obviously a lot more now. And mainly we taught symptoms. Breathlessness and cough are our main ones. Pain is particularly difficult, and it's helpful having a palliative care consultant who's a specialist in pain management there too. And we will talk about prognosis, progression, advanced care plans if the patients want to. We have to slightly put our toe in and work out if they want those conversations, because not everyone does. We talk about preferred place of death if that's what they want, future hospital admissions, and have actually talked about no further acute NIV for certain patients as well, and made sure it's on our system. It gives them the opportunity to talk about their worries. For instance, one patient was worried, will I die short of breath? We then talk about carbon dioxide level going high, going sleepy, and they've got a sense of satisfaction. It's unlikely they're going to die gasping for breath, and that's important to have that conversation. Referrals from clinic, over 50% we ask to see the hospice physiotherapist who does non-pharmacological management of breathlessness, to go to see people at home. A significant number come to the day therapies unit, where is available bereavement, counselling, social worker support, and some have actually had booked respite care for support for carers as well. From the IPOS questionnaire, significantly there has been improvement in mobility following on from clinic, and also improvement in people's feeling of anxiety about their illness. There isn't a reduction of breathlessness, but I wouldn't expect that. What we want people to be doing is able to do more from a functional point of view whilst managing their breathlessness as well. And we've had very positive feedback from patient and carers from clinic. Also, place of death, about 40% of the patients so far have died, have been seen in clinic. And on the left-hand side is our data here. So 53% of patients have died at home, and 39% have died in the acute hospital, with some within the hospice and care home. The data I've got compared on the right is Elkington, who published in 2005 that showed 67% of patients died in hospital and 25% in home. So whilst I haven't got a before and after for our clinic, it shows the shift is more patients are dying at home, which is where they want to be. What we've also shown between 2012 and 2016 has been a significant increase in palliative care contact with our COPD patients. More than 300% increase in the hospice day unit, more being seen by the home care team, more patient stays in the hospice, which is mainly respite, and actually patients dying at the hospice. Trying to get that time right and in is difficult, but then more of them are dying there and have more outpatient appointments. So we have more closer working with palliative, and the patients are benefiting. So in summary, we do have different examples of integration respiratory across Wolverhampton. There are more than that, obviously wider, and between primary and secondary care, between respiratory and other specialists, and now is the time of the NHS plan to develop that more. Thank you.